So bonjour, hello, welcome to the COVID-19 Immunity Task Force first event, this one in collaboration with Canadian Blood Services and Héma-Québec. My name is Caroline Faneuf. I manage communications for the COVID-19 Immunity Task Force. Je voudrais commencer en vous disant que...
I'd like to start by telling you that we are offering simultaneous interpretation this afternoon. You can choose to listen to the webinar in French only, in English only, or with the original audio. So look at the bottom of your screen. There is a globe written interpretation. That is where you will be able to choose the language of your choice.
For this webinar today, just look at the bottom of your screen to the globe with interpretation written there. You can choose to listen only in English, only in French, or in the language that's being spoken by the presenters. A few more housekeeping notes. This webinar is being recorded and will be available on our website in the next few days. The chat has been closed to attendees and we'll be taking questions at the end of the presentation. We'll be welcoming your questions, actually. You'll be able to ask questions by typing them in the Q&A at the bottom of your screen, and they'll be read out to our speakers. So without further ado, I would like to present our four speakers that we'll be hearing from today. So first, Dr. Timothy Evans, who is the Executive Director of the COVID-19 Immunity Task Force. We have Dr. Sheila O'Brien, who is the Associate Director of Epidemiology and Surveillance and Primary Investigator at Canadian Blood Services. We've got Dr. Marc Germain, who is Vice President, Medical Affairs and Innovation and Primary Investigator at Héma-Québec. And we've got Dr. David Buckridge, who's COVID-19 Immunity Task Force's Scientific Lead for Data Management and Analysis. So now I turn it over to Dr. Timothy Evans. Tim?
Merci Caroline et bienvenue.
Thank you, Caroline.
À toutes.
Welcome to everyone.
I'll just provide a brief introduction here and then we'll move to our presentations. First, a word on the COVID Immunity Task Force mandate. We were established a little over a year ago in April of 2020 with a mandate to assess the extent of SARS-CoV-2 infection across Canada, understanding the nature of immunity arising from infection, to look at how we could develop and make sure people had access to good quality antibody testing, and more recently, as vaccines have come into the picture, to monitor the effectiveness and safety of vaccines as they're rolled out across the country. We've done this by trying to catalyze and take advantage of smart study designs and institutions that are ready built to help in this effort. And we're focusing on two of those institutions today, Héma-Québec and Canadian Blood Services. Next. Part of the challenge and why we think serology data is so important is that the testing for acute infection is only giving us part of the bigger picture of infection arising from SARS-CoV-2. And this relates to issues that testing systems perhaps were not accessible to people who had symptoms, that many cases of infection don't develop symptoms that drive people to go and get tested, or that in a significant fraction of the total cases, people have no symptoms at all. So in this picture here, one of the drivers of the seroprevalence efforts has been to try and get a sense of how big that iceberg is underneath the water, in addition to understanding the acute infection that's been diagnosed with the RT-PCR swab test, which is above the water. Now, to do that, we not only invested in studies in Canada, but we wanted to track what was going on globally. So we helped develop something called SeroTracker. Next slide. So SeroTracker is looking at, in an ongoing and real-time way at all of the seroprevalence studies that are ongoing globally. And so it is a knowledge hub. It's drawing and synthesizing results on the serosurveillance efforts worldwide. We started it back in April last year as an important complement to understand Canada's situation with respect to seroprevalence in relationship to all of the studies globally. Next. Thus far, we found, after looking at over 1,500 studies across 100 countries, encompassing 15.4 million people, that the seroprevalence estimates from national studies are low. So immunity arising from infection, when you look at national studies, the median is about 4.6%. An interquartile range of 1.9 to 7.7%. But I think the general finding that we're finding that is that across countries is that after first and second waves, that seroprevalence measuring infection-acquired immunity is low. There's variations on this across countries, but when we looked at the iceberg effect, the number of acute infections diagnosed with RT-PCR or the nasal swabs, and compared to the numbers found through seroprevalence, you get different ratios which give a sense of the magnitude of infection that's not picked up by acute infection testing, but it is picked up better through seroprevalence. And we can see on the right-hand side of this slide that those ratios vary from as low as 4 times as many cases in the European and Central Asian regions to 10 times in high-income countries, and those would include Canada, to 13.1 times in Latin America and the Caribbean, and in South Asia, perhaps as much as 107 times. Now, clearly, these reflect a whole set of different conditions related to the extent and scope of testing, but you can see that there is regional variation in these ratios, or what the bottom of the iceberg looks like. Next slide. Importantly, in this work and for today's presentation, through the SeroTracker work, we found that blood donor studies are representative of the general population. And what we did here is we looked at the average levels or the median levels of seroprevalence through household surveys, which are done on representative populations, versus residual sera, which is often stored by public health agencies, and the blood banks. And we found that although the median seroprevalence is slightly lower in both blood banks and residual sera studies at 4.2% compared to household surveys at 6.9%, that difference is not significant if you look at the interquartile ranges. And so I think very importantly for today, although no samples ever perfect, what we're finding through this empirical evidence from SeroTrackers is that the blood banks provide us actually a very good window into what's going on in the general population more broadly. Next slide. We found out very importantly after the first wave of infection, thanks to the work of Héma-Québec and Canadian Blood Services, that seroprevalence after the first wave in Canada was in fact very low. And here across the provinces, seroprevalence 1% or less. And even when you looked at cities, and particularly cities where you had more clustering of infection, you saw that the seroprevalence rate did not move above 1.5%. This was an incredibly important public health message to send to policymakers in July and August, because what it said was two things. One, on the first positive side, Canadians did a tremendous job in limiting the extent of infection during the first wave. But in terms of the second wave, and the second point that was incredibly important, in terms of risk associated with further development of the pandemic, we remained at very, very high risk given the very low levels of population immunity. And indeed, what we saw was the second wave, which has traveled and affected many Canadians since that time. So today we have an opportunity to look at what the picture looks like into the second wave. And with that, next slide, I will shift to Dr. Sheila O'Brien, who, as Caroline suggested or indicated, is the Associate Director of Epidemiology and Surveillance and the primary investigator at Canadian Blood Services. Sheila?
Thank you, Dr. Evans. Next slide. So this figure shows the reported COVID-19 cases since the start of the pandemic. Our seroprevalence study began in the middle of the first wave, so in May, and I'll be presenting data up until January, late in wave 2. We tested over wave 1. We stopped for a couple of months in the summer, so you can see there shown in gray in August and September. And then we resumed in October. We switched assays in January, which I'll tell you more about momentarily. And the study does continue on, so there will be more data coming after January. We used the Abbott SARS-CoV-2 IgG assay, which detects antibodies to nucleocapsid. And this is indicative of natural infection. So in January, we tested on the Abbott, but we also retested all of our samples on the Roche system, which includes a nucleocapsid and a spike-based assay. So because vaccines use spike protein, the spike-based assay will detect antibodies to both vaccination and natural infection. And by comparing the two, one to nucleocapsid only, which is natural infection, and spike, which is both natural infection and immunization, we will be able to assess whether the infection is natural or vaccine-induced, or the antibodies vaccine-induced. And importantly, the spike-based assay is semi-quantitative, and this will be needed to monitor the impact of second doses. So data were weighted to better reflect the general population and to adjust for assay characteristics. So this slide is showing you the seroprevalence by age in wave 1 and then in January down at the bottom. And you can see that in wave 1, the seroprevalence was very similar by age group and very low, less than 1%. By January, you see a clear separation with the highest seroprevalence in the youngest age group, shown in the brown on the far right, and it progressively becomes lower as age increases. So moving to the left to the light blue, which is the 60+ age group. So a material deprivation index was calculated based on postal code for household, mainly for household income. And there's not much difference in the quintiles in wave 1, shown on the top left. But by January, those in the most deprived quintile, which is the light blue to the far right, have much higher seroprevalence compared with the least deprived. These data were made available in March in time to inform vaccine rollout. And indeed, in some jurisdictions, they targeted vaccination into the lower income areas. We also identified increasing disparities among racialized donors compared with Caucasians. So here we are comparing the seroprevalence between the three assays. So shown in red, the two nucleocapsid-based assays are quite similar, with the Roche slightly higher and that would be because it is a total antibody. So would include IgA and IgM. So maybe picking up some more recent infections. It's very good that these two are similar because it means that as we've switched over our assays, we will have continuity from what we were measuring with the Abbott N assay up until January, and then going forward with the Roche. And then you can see that the Roche is significantly higher, and this is because it is including both vaccine-induced immunity as well as natural infection. So we ask all of our donors when they come in to donate if they have been vaccinated in the last 3 months. And in this sample, which is about 35,000 donors, there were 511 who reported that they'd had COVID-19 vaccine. So that's about 1.5%. Remember, this is January. The majority were female and aged between 25 and 39. So consistent with targeting vaccine towards healthcare workers. We had 245 donors who also reported their date of vaccination. And the mean time since vaccination was 10 days. So we had a lot of people in this sample in January that had very recent vaccination. Of those that had more than 2 weeks since they were vaccinated, 95% were reactive based on the S assay. And vaccination rates were similar by province, ethnicity, social, and material deprivation indices. So this figure illustrates the correlation of results between all Roche S positive donations and Roche N results, and it's on a log scale. So you can see the red circles. These are the vaccinated donors, and the blue ones are donors who did not report vaccination. So to the right, that big cloud of blue, those are people who have nucleocapsid and S, and they would be people with natural infection, plus a few red dots in there. That would be people who had both had been vaccinated, but also had a history of infection. And then to the left there is that column of mostly all red dots. Those are people who were vaccinated. They are S only, so they don't have nucleocapsid. And you can see there is a very clear distinction between these vaccinated S only and the people who were a natural infection, so that we will be able to distinguish to a considerable extent between people who are vaccinated and people who have natural infection using these two assays. So this slide is showing the time trends since we began our seroprevalence study. The earliest date we have is April. And you can see on the left, the first half of the graph, there really is extremely low seroprevalence across the country. And then as fall comes in, so about November, we start to see an increase, but always very low seroprevalence. So it's less than 5% at any one time. Now you can see there's a gray line there. That is the Roche N, so not too different from the Abbott N. And then the green line is showing the Roche S, which with the difference between the gray line and the green line is the impact of vaccination. So what we expect to see in our future samples is that the gray line, it might increase a little bit, but the green line, as the percentage of people vaccinated goes up, it's going to go up, 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 up. And this is a comparison by regions over time. On the first half of the left half of the graph, you can see similar to the last one, there's really not too much happening, very low seroprevalence. As we move into the second wave, the increase overall in Canada, you can see it is driven by increased rates in Alberta and the prairies. So in conclusion, in January, seroprevalence was still quite low, regardless of the assay used. So you can see how we were able to move into quite a devastating wave 3 with such low seroprevalence and very little protection for the community. By January, 1.5% of donors had reported receiving a COVID-19 vaccine. And among those, the date of vaccination, most had been, it was still too early for them to mount an immune response. So with the Roche S and N assays, we are well positioned to monitor antibody response to vaccine rollout and the impact of the second dose as we move forward. And now it is my pleasure to hand over the virtual floor to my colleague, Dr. Marc Chaman.
Thank you, Sheila. Alors, bonjour. Il me fait grand plaisir aujourd'hui de vous présenter.
Good afternoon. It's with great pleasure that I will present the results of the seroprevalence studies that were done amongst blood donors at Héma-Québec. Starting at the beginning of the pandemic, Héma-Québec had discussions with provincial public health authorities in order to plan seroprevalence studies amongst blood donors. And that, of course, in order to estimate the progression of the pandemic amongst the general population. It was a first study done after the first wave around the month of May last year. And I will very briefly tell you the results of this first study. But my presentation today will focus on our more recent study that was carried out early in the year after the second wave of the pandemic in Quebec. This study was done with roughly 8,000 blood donors that gave blood during one of our blood collection in the province between the end of January and mid-March of the current year. Let me remind you that blood donation is offered for adults 18 years and over in Quebec. And in addition to answering to the regular eligibility criteria for blood donation, the people who had COVID recently won't be eligible until 14 days after there are no longer any symptoms. So the screening of antibodies was done with a test developed at Héma-Québec by the research team, Dr. Bazin's research team, in collaboration with Professor Andrés Vizzi at the CHUM. It is a test that detects antibodies against the virus spike. So when the test is positive, it's after an infection or after vaccination. The test was assessed with a known serum panel, positive and negative, and it has shown a good performance in terms of sensitivity and specificity. Finally, it's important to specify that the same test was used in both seroprevalence studies done in May 2020 and the one done more recently after the second wave. This greatly facilitates the comparison of results and the assessment of the progression of the infection within the population. This is to illustrate the time when we took the samples for both studies compared to the first two phases, two waves in May 2020 for the first study and in February, March of the current year for the most recent study. So the results at a high level obtained in both studies. For the phase 1, we had observed a seroprevalence of 2.2%, whereas seroprevalence was measured at 15% in the second study and carried out more recently. So in last March, we estimate that 15% of the population had developed antibodies against COVID in Quebec, be it because of infection or because of vaccination. You'll remember, of course, that vaccination started early in the year. Next slide, please. In particular, amongst health professionals, so that we could expect that a proportion of donors that were included in the study could develop antibodies, not because of infection, because of the vaccine. For our study, we had access to the vaccination registry maintained by the government. Therefore, we were able to identify for each of the participants if he or she had received the vaccine and at what time compared to the time when the blood donation was done. And in fact, it's close to 8% of participants to the study had already received the vaccine at the time of their inclusion in the study. And it's interesting to note that when the time between the vaccine and the donation is of 2 weeks or more, the vast majority of participants that had been vaccinated had antibodies, which is of course expected, but still reassuring regarding the effect of the vaccine. If you could click to show the rates, yes, those are the rates, close to 100% of seropositivity amongst individuals that were vaccinated 2 weeks and more before inclusion into the study. These are the results of seroprevalence per health regions in Quebec, including or not vaccinated individuals. The first thing to note is that when we consider only individuals that are unvaccinated in the column to the right, it's now 10% of them who have antibodies compared to 15% when we consider total seroprevalence. That means that in last March, roughly 10% of the population had a COVID infection. The other 5%, they have antibodies because of the vaccine. When we consider results per regions, we can see, and it's no surprise, that the seroprevalence rates, the highest ones, could be found in the Greater Montreal area, as was the case during the phase 1. What's interesting to note is to compare the seroprevalence rates amongst unvaccinated individuals with the infection rates declared in the health systems in each region. And the figures concerning infection rates diagnosed by PCR are shown in the last column to the right on this graph. You can click to show this. Yes. Next slide. On this graph, we can show the correlation between seroprevalence measured amongst blood donors on the y-axis compared to the infection rate declared in the health system for each region, each health regions. And we can see that there's a good correlation between the two measures. That is very reassuring regarding the representativity of data stemming from blood donors versus the epidemic amongst the general population. Another interesting data concerns seropositivity. According to the ethnic group, this confirms observations mentioned by my colleague, Sheila O'Brien. We observe that the rate is roughly twice as high amongst non-Caucasian compared to Caucasians. That goes for unvaccinated and vaccinated individuals. And by the way, this is a gap that does not seem to be explained regarding material and social deprivation indices results that I don't have the time to present to you in detail, unfortunately. So this is to mention that we have assessed the proportion of individuals who went from a seropositive status after the first wave to a seronegative status. So that's called seroreversion. In order to estimate the impact of this seroreversion on the phase 2 study data, in summary, we've measured that roughly 20% of individuals infected in the first wave seroreverted, so got a seronegative result long after their infection. But given the fact that there have been less infections in the first wave, even by correcting results for that factor, the results that I showed earlier do not change in a significant way. Consequently, as a conclusion, next slide, we can state that in Quebec, at the end of the second wave, 15% of the population had SARS-CoV-2 antibodies. By extrapolating the seroprevalence data to unvaccinated individuals to the entire adult population in Quebec, it translates by roughly 600,000 infections, twice as more as the number of cases surveyed in the health sector. Something that is quite measurable when we had done measurements during the first seroprevalence study. And these results show that the vast majority of the population, the adult Quebec population, remained susceptible to SARS-CoV-2 infection at the time of the study. And finally, the data confirmed that the vast majority of vaccinated donors develop SARS-CoV-2 antibodies. Thank you. And I'll now give the floor to my colleague, Dr. David Buckridge, Senior Scientist for the CITF. Thank you very much, Dr. Germain.
My pleasure to present to you some of the work that I've been leading at the task force to essentially pull together some of the results that you've seen from Héma-Québec and the Canadian Blood Services and other sources to provide regular estimates of the cumulative proportion of Canadians with immunity to SARS-CoV-2. And so this is work, as I mentioned, led by the Canadian COVID-19 Immunity Task Force, together with SeroTracker and Precision Analytics. Next slide, please. So the methods that we're using here, the goal really is to take as much available information as possible and triangulate across different sources. So that includes the seroprevalence estimates you've just heard about, but also other regular epidemiological indicators such as mortality in the population to try to exploit the known relationship between immunity and previous infection to really get the best estimate in an ongoing way of what's the total population in Canada and Canadian regions who have immunity to SARS-CoV-2. The current implementation, the model that we're using, is a statistical model, which was published late last year, the version that we're basing our work on. It's essentially a statistical model fit separately to each of the geographic regions in Canada, but then allows us to pull that information together to provide Canadian estimates while also seeing what's happening in each region. And the different data sources that we're triangulating across, I'm showing you there. So we look at daily mortality data from each region, cumulative age, sex counts of deaths after we exclude deaths that occur in long-term care facilities. And then we also bring in some information on age-sex specific infection fatality ratios, which is simply the ratio between the number of true infections and the number of deaths seen in a population, and of course the seroprevalence results. Now, this approach does allow us to also incorporate data on vaccination, but what we're going to report today is only information about immunity through natural infection up until approximately mid-February. And in future releases, we'll make available results from this modeling method that also incorporate data from vaccination. So the main result for Canada, you can see here in the plot on the left and in the figure on the right. It's 4.2% is our best estimate of the approximately mid of February, February 18th, with a credible interval, as you can see, that ranges from 3.5 to 5. And that's almost exactly the median that Dr. Evans reported at the start of this presentation in terms of countries such as Canada and what level of natural immunity or immunity we have through infection in a country like Canada. You can see in the curve on the left, the darker, very central line is the mean, and then there's a 50% credible interval, and the very light outer envelope is the 95% credible interval. And the steep rise you can see in April, and again in October, December, those correspond to the first and second waves. Now, of course, as I mentioned, we can look at this by region because the model is initially fit by different regions, as you can see here. And the plots, of course, are quite small, so it's hard to make anything out. And I'll move to a larger plot in a second. But what I want to just make clear here is that all these plots are on the same scale. 10% is the top line. And you can see that some provinces such as Manitoba, Saskatchewan had relatively high estimates. Others, such as the Atlantic provinces, had very low estimates. So the bottom line, which I think you've heard already, is that there was considerable regional variation across the country. But overall, by mid-February, at the end of the second wave, pretty much all regions of Canada and Canada overall had a relatively low proportion of people with immunity through natural infection to SARS-CoV-2. Now, if we look a little more closely, just to give you a bit more detail about how the model works and how we incorporate the different estimates, I'm showing you just two example provinces or regions in Canada, Alberta and Ontario, Alberta on the left, Ontario on the right. And what I'm showing you now is the model output you saw for all of Canada, which is the line, but I'm also now showing you the seroprevalence estimates, where are little dots with the vertical lines, which are the confidence intervals or the measure of uncertainty around each seroprevalence estimate. The estimates in red are the ones that were provided by the Canadian Blood Services. So you can see how valuable those estimates are in allowing us to try to calibrate or fit this curve. And the reason why, for example, in Ontario, the line does not go through all the points is because we're trying to triangulate, as I mentioned, or compare those estimates to other types of data and try and get the best possible model fit, which really takes account of all available information. The vertical blue sort of shading you see across the plot are the temporal intervals covered by the different seroprevalence estimates that we can fit into the model. So with any statistical modeling process, of course, it's very important to check assumptions and try and validate as much as possible the model from multiple perspectives. And so that is work that we've been doing extensively and will continue to do. There are a number of different components or outputs of the model listed on the slide, as you can see, that we attempt to validate. The plot on the left is showing you the model estimates for the infection fatality ratio I mentioned before. And as you can see, the ratio is relatively low in younger age groups, then rises into older age groups. And we also notice a sex differential in older age groups, particularly with a higher infection fatality ratio in males. And these estimates are very similar to what we see reported in the literature in terms of age-specific and sex-specific infection fatality ratios, along with other validation steps, gives us reasonable confidence in our model. However, there are some limitations that should be noted. There are relatively small number of seroprevalence estimates available, particularly in some regions of Canada. As Dr. Germain mentioned as well, and I believe Dr. Bryan as well, seroreversion is an issue where people may lose or no longer be detectable through antibody testing in terms of having antibodies in their blood at some point following infection. We're not currently accounting for that in the model, and that will probably slightly increase the values once we're able to do that. We have also done our best to adjust the assays that we're basing the different seroprevalence estimates on in the model, but they've not really all been adjusted against a common reference panel. And so that is, of course, work to be done. And there probably is still all the work that can be done to also adjust for different sampling biases that may affect how the different estimates are made available. However, we do the best that we can to adjust for those before we place them into the model. So moving forward from here, the next step really is to try to look at overall immunity. So as I mentioned, these estimates we're providing right now are really for only infection, or sort of immunity through infection, natural infection. But of course, as the vaccine coverage increases dramatically, the contribution of vaccination to overall immunity populations is becoming much larger. So we want to be able to combine both natural and vaccine-mediated immunity in the same model. And that will require us to make use of vaccine coverage time series, and also to make use of the results such as Dr. Bryan mentioned from seroprevalence assays that allow us to distinguish between immunity due to natural infection and immunity due to vaccination. We'll also be making some improvements to the adjustments of seroprevalence estimates for sampling bias and test characters, as I mentioned. We'll also be improving our estimation of true infections by trying to incorporate other types of information. Right now, as I mentioned, we're primarily leveraging death data, but we can also bring into the model data from antigen testing for cases in clinical contexts as well. So to summarize then, the work that I'm presenting led by the task force here is really to try and synthesize and triangulate across multiple data sources to provide the best possible estimate of cumulative seroprevalence, so the proportion of the population with immunity to SARS-CoV-2, both in Canada and by region. As I said, our initial estimates indicate that there are overall low levels of natural immunity coming out of the second wave. However, we did see some variation in that level of immunity across geographical regions in the modeling that we did. These types of estimates will be released by the Immunity Task Force, the COVID-19 Immunity Task Force, on a monthly basis from now forward. And as I mentioned, in future releases, we'll also be incorporating vaccination and ongoing refinements into the model. And with that, I'd like to pass the virtual floor back to Dr. Evans.
Great. Thank you very much to our presenters, Dr. O'Brien, Dr. Germain, and Dr. Buckridge. And it's now an opportunity to take questions. I'm going to let Caroline Phaneuf distribute the questions, and there are a bunch of them in the chat, which we'll go through, and if anybody wants to go live with their voice, they're welcome. Caroline? Thanks
very much, Tim. So we have a first question from Bonita Lee asking, this is for Dr. O'Brien. Many thanks for this presentation, and to the first two presenters. Well, this was a while ago. There was a want for a clarification on the two slides, Dr. O'Brien, on age and material deprivation data. She was asking which assay was used for those tests, the nucleocapsid tests.
Oh, well, thank you, Bonita. So the assay was the Abbott nucleocapsid. So I did that because it's better to compare with the same assay from from two different time periods. So on the go forward, we'll be using the Roche, but that was with the N nucleocapsid, Abbott nucleocapsid.
Great, thank you so much. The next question is for Marc Germain. Asking, were the results for seropositivity post-positivity from the Quebec study reflective of 2 doses or 1 dose? And do you have it subcategorized by vaccine type?
Yeah, okay, I would have to go check the actual data, but my guess is that the vast majority, if not the totality of the participants only got their first dose of the vaccine because the vaccination campaign had just started. So this is really reflective for the vast majority. This is reflecting the seroconversion after a first dose of the vaccine. The registry does contain the information related to the type of vaccine. We haven't looked at that yet. We could. I suspect that given the very high rate of seropositivity after the first dose, given at least 2 weeks after that, we won't see a lot of any major difference, but that remains to be evaluated by looking actually at the data. It could be interesting to see if the rate of seroreversion does vary depending on the type of vaccine. I'm not sure we have enough data at this point, but it will be really interesting to look at.
Great, thank you very much, Dr. Germain. The next question is, it seems the most of these very valuable analyses have so far been performed for the first 2 waves of infection. When can we expect seroprevalence estimates that include the 3rd wave in regions where a 3rd wave has occurred? And where will these results be published, and when will they be available? So Dr. O'Brien, do you want to answer first for Canadian Blood Services?
Certainly. So we, having switched over our lab to the Roche system, we did not test for February, but March is actually now tested, and we can expect the report within the next 2 to 3 weeks. April is being tested at this time, and will be out shortly thereafter. And then we will be starting May, which we still have to wait for May to finish. So, it will be in the next few weeks. You will see a lot of data coming through.
All right, Dr. Buckridge, did you have something to add?
Yes, so thank you. Yeah, so this is our first release of the modeling work that we're doing to try and synthesize different results, but we will be producing these results every month. And so future releases will incorporate additional data through this 3rd wave and going forward.
All right. Tim? Dr. Evans?
Yeah, thanks. Just to say that we have the COVID Immunity Task Force has a number of other seroprevalence studies for which we're expecting data in the coming weeks and months, including from Statistics Canada, as well as some other sources. And so those will be brought online and will be used by Dr. Buckridge to supplement the models, but they should give increasingly insights on immunity arising from vaccination.
Excellent. So the next question is again for Sheila. Did you account for seroreversion in your data, believed to be higher for anti-N rather than anti-S? And how much would you estimate this would increase seroprevalence?
No, we did not adjust in the results that I showed you. We are carrying out a separate study, of which some of the results actually are in that data, in which we have compared the test results of Abbott with different assays. And I think it's, as time goes by, there is a little more seroreversion. I think it could be anywhere up to 50% more or double by January.
Great, thank you. A question for Marc Germain. Do the Héma-Québec data suggest the time frame to seroreversion or rate of decay?
Yeah, that's a great question. Of course, when we estimated the rate of seroreversion in people who were identified as seropositive in the first wave, we only had 2 time points for measuring antibodies. You know, the first time when they tested positive, and then 7-10 months later to see whether they were still positive or not. So we don't have a clear picture of the kinetics of how these antibodies decayed. However, my colleague René Bazin, in collaboration again with Dr. Finzi, they did look at the profile of the decay of antibodies in convalescent plasma donors, showing that the decay is starting, if I recall correctly, it's about 10-12 weeks after the infection, and then it still goes down. I don't know exactly, because I don't think we did serial sampling beyond that time frame, even on these donors. But after several months, it's a lesser proportion of convalescent plasma donors who serorevert. And that's probably due to the fact that, you know, since they were identified as being infected, they were symptomatic. And we know that people with symptoms will tend to have more persistent antibodies compared to those who are symptom-free. Also, the seroreversion rate in those donors who were seropositive in the first wave, you have to take into account that given the very low prevalence, there were probably a fair proportion of false positives initially. So that's kind of normal that you would see some of them become seronegative. So that's why the estimate for seroreversion overall is in the range of 20%. But as for the kinetics, in terms of when exactly does it become negative, we don't know yet.
Right. Thank you, Dr. Germain. Dr. Buckridge, for you, are children included in the denominator for immunity rates?
In the modeling work, yes, we do include children in the denominator. So the general population assays generally would depend on the different source. So some are testing in children, some are not. But generally speaking, yes, they're included in the denominator for the modeling work.
All right, thank you. I don't know who would like to answer this one, actually. A question, is there any data on Indigenous populations?
I can answer that easily for Héma-Québec. Unfortunately, no. I don't know if Sheila wants to add to that.
No, very little.
Dr. Evans, go ahead.
Yeah, there are other studies in the CITF portfolio that are that have a larger percentage of Indigenous populations, and in the context of vaccine surveillance, we have a number of dedicated studies looking at seroprevalence, as well as a number of other issues related to safety and efficacy of vaccines that are done with Indigenous communities.
Thank you, Tim. Des questions en français pour Dr. Germain.
Questions in French now for Dr. Germain. How do you explain seroprevalence that is much higher among Blacks and Latinos? Very good question. Unfortunately, I don't have an explanation. We have to remember that the main goal of this study was not to study disparities between ethnic groups. This is a bonus of finding. I think that the result is quite robust. It was observed as well in the study carried by the Canadian Blood Services. In our analysis until now, as I mentioned in my presentation, what we've done is that when we stratify according to deprivation, social and material deprivation indices, the difference persists among ethnic groups, so it cannot be explained by socioeconomic status. But honestly, I think we require further studies to explain why there are these differences. Is this due to different behaviors in terms of protection, social distancing, or other factors that we are unaware of? We don't have an answer for the time being. For the time being, it's only an interesting finding. We can generate research assumptions, but I doubt we'll be able to answer the question simply with current data stemming from our respective studies. Thank you, Dr. Germain.
Was I think this is more for Doctors O'Brien and Buckridge. Was the large proportionate increase in Quebec in wave 2 versus wave 1 blood donors seen in other provinces?
We did see quite an increase out in Western provinces, so Manitoba particularly, and Alberta. So the pandemic has been different in different provinces, but that is for sure.
Dr. Buckridge, did you have anything to add?
Not really. I would say we saw the same pattern. Definitely there were higher, quite large jumps between first and second wave in some regions of Canada, particularly in the prairies as well, in Manitoba, Saskatchewan, we saw that. Again, the region-wide, I think if you drill even deeper into provinces, there's a lot of regional variation within provinces too. So I think it's the story is, as we mentioned before, there is considerable variation, but the average remains probably around where most countries are, like Canada, as Dr. Evans reported, or as we found to be around 4.2%.
Great, thank you. Dr. Evans, I'm going to ask you this one. How is Canada comparing with the US in terms of seroprevalence rates pre and post-vaccination?
Thanks very much. Well, the simple answer is we don't have the adjusted seroprevalence comparisons at the moment, which would compare Canada and the US with respect to both infection and vaccine-acquired immunity acquired from infection and vaccines. But in general, the infection-acquired immunity in the United States was higher than in Canada. And so that is, I think, a reflection that if you looked at their baseline from infection-acquired immunity prior to the beginning vaccination across the United States, it was probably closer to between 10 and 15%. Again, a lot of interstate variation. But now, of course, with the vaccine-acquired immunity, as we've all seen, their vaccination rollout has been quite brisk. And so you can see that they're probably reaching levels of 40, 50, 60% in both infection and vaccine-acquired immunity at this point in time. Again, a lot of interstate variation.
Great, thank you. I'm gonna have to ask, we have a lot of questions, but unfortunately, we can only get to one more before we end. So for Doctors O'Brien and Germain, interesting one. Will you ethically be able to look at the correlates between the blood group and the rates of natural infection?
Yes. Yes.
Dr. Germain?
Well, ethically, we would need to get the approval from our board, but I don't see the problem in doing that kind of study. Actually, it has been, those types of studies have been done by other groups. Quite frankly, I haven't kept appraised of the general consensus in that regard, but certainly our results could be used for that purpose, our data set anyway.
All right, thank you very much. I want to thank all four of our presenters, Drs. O'Brien, Buckridge, Evans, and Germain, for their presentations today. Thank you very much. Once again, the French presentation is available in the chat if you'd like to download it. Both the English and French presentations will be available on our website tomorrow, COVID-19immunitytaskforce.ca. And the recordings of the webinar, both in English and separately in French, will be available shortly on our website. We will take note of the questions that came through that we were unable to answer and try to provide responses, especially for those not answered on our website, especially in the coming days. Alors, je veux vous remercier pour votre présence aujourd'hui.
I would like to thank you for your participation today. I'd like to remind you that the presentation in French is available in the chat right now. It will also be available on our website tomorrow as well as a presentation in English, and the webinar in French and in English will be available on our website in the coming days. Thank you very much. Enjoy the rest of your day.
Bye.